right. Hello, everyone, and wanted to welcome you to today's PQA Quality Forum Webinar. My name is Amanda Ryan. I'm Director of Education here at PQA, and our topic today is integrating pharmacists in value-based programs to improve performance on PQA measures. So as we do with every quality forum, I would like to call your attention to some housekeeping items. So first, please do submit your questions during the presentation using the Q&A feature that's located at the bottom of your screen. I will read your questions for our speaker to answer at the conclusion of her presentation. And then also the webinar recording and the slide deck will be available to PQA members within the week following the presentation, and you'll be able to find that on the member resources section of the PQA website. And I'm excited to announce that today is the first ever quality forum that is ACPE accredited for Pharmacist CE. Pharmacists can earn 1 hour of credit by attending today's live session and completing the following steps. First, we will share a secret code at the end of the webinar. Please record this code as it will be used to validate your attendance at the session. And then second, please complete the SurveyMonkey evaluation by October 14th. I'll have additional details for you about that evaluation at the end of the webinar. Your credit will then be uploaded to CPE Monitor in approximately 5 weeks from today. And it is now my pleasure to introduce today's speaker. Magaly Rodriguez de Bittner is Professor and Associate Dean for Clinical Services and Practice Transformation and the Executive Director of the Center for Innovative Pharmacy Solutions at the University of Maryland School of Pharmacy. She is a fellow in population health at the University of Maryland Health System, working with interprofessional value-based integrated networks, and she is also an American Pharmacists Association trustee. She developed programs at the University of Maryland Medical Center Quality Care Network, eHealth Center, and Maryland P3 program. She has received many awards, including the 2019 NAP Creativity and Practice in Education Award, as well as the 2015 APHA Foundation Pinnacle Award. Magaly, thank you so much for joining us. I want to welcome you today, and we will switch over for you for screen share. All right, Magaly, I am not hearing you. I'm not sure if you're on mute potentially.
Yes, I am. Can you
okay.
see my screen?
I'm seeing it in presentation view right now.
Okay. What about now?
That's perfect.
Okay. You guys are seeing my screen, and so again, good afternoon, everyone. It is my pleasure to be here with you today, and I thank PQA for asking me to come and share with you the role of the pharmacist, particularly in population health, but as it relates to integrating them into these value-based models. I have no conflict of interest to declare related to this presentation. This is the objectives that we're going to be discussing today, which is again describing how pharmacists are integrated into these value-based population health programs in a large healthcare system. So for some of you, this may be a little bit different because you probably have heard a lot about the community pharmacists integrating themselves, but this is within a large healthcare system. I'm going to talk about how we are tracking PQA measures and integrating them as part of the overall contract, and then discuss with you particularly examples of some of the programs where we're actually tracking these PQA measures. Just to level set, I wanted to kind of talk a little bit about value-based care, some general principles. And again, the goal here is that we all come from the same point of view. And remember that the 4 main goals of these accountable care programs are to produce better outcomes, to produce a better patient experience, improve the clinical experience of providers, and reduce the national high healthcare costs, particularly those healthcare costs that we call unnecessary healthcare costs. So again, these are some of the major overall goals. There are many value-based programs out there. Some of them are part of the CMS, Center for Innovation. And one that you probably are more familiar with is what's called the CPC Plus, which is, again, a comprehensive primary care program that aims at integrating an interprofessional team to support primary care practices. The reason that I bring this up is because when I describe to you one of the programs that we're doing, you're going to see that it's a variation of the CPC Plus, but very specific to Maryland and the status that we have within Maryland, which is that we have a waiver with CMS that makes our state a little bit unique in terms of how the funds from CMA flow for Medicaid and Medicare. And you will see that while it's very similar to the CPC Plus, has some differences. So again, we know that in the private sector, many of the private health plans, as well as CMS, is really introducing this whole concept of value-based contracts. So what are the types of payments that we see within these models? We really see a potpourri and a variation of many of these. Some of them are combined, some of them are by themselves. But in some of these programs, they still maintain some of these fee-for-service, but they may attach to it a bonus payment or a penalty based on performance of certain quality metrics. So again, depending on the performance of the providers, then they may get a bonus or a penalty. Some other programs, there's a care coordination of a management fee that gets paid to the providers, either in a monthly basis or yearly. So again, there's some amount of money that is provided to provide these services to the beneficiaries or to the members of a healthcare plan. Others is what we call risk sharing, where again, providers and payers will share if savings are achieved in the total healthcare cost savings. And then we also have something called bundled capital payment, where again, there is some amount of money that is provided either to a health system or to a provider group to take care of all the needs of that particular patient. When I talk to you a little bit about the Maryland, in Maryland has been under these bundled payments for Medicaid and Medicare for a long time. And now health systems, those hospitals, have this bundled payment structure where they're given a total amount of dollars for attributed patients that they have to manage all their needs, not only inpatient, but also outpatient. So that has given birth to a lot of different innovative programs where health systems are integrating themselves with primary care practices that are providing care to those patients that are attributed to them. So as we look at the literature and we look at different publications, I wanted to just highlight one that is in the website of PQA, which is really looking at what strategies we could use to expand value-based pharmacist-provided care. In this particular action guide, there are very nice practical tips on how pharmacists can integrate themselves and work as a team with healthcare payers and other stakeholders. This particular publication highlights a lot community pharmacists and opportunities. Through my presentation, you're going to see that I'm going to highlight more pharmacists integrated within a healthcare system. Again, in this particular publication, talks about these outcome-based quality performance measures, and it does a good job in showing what is the vertical integration in clinical care, highlighting for you that there are certain quality measures that will be collected either from the patients, from the pharmacists, from the providers, from the healthcare plans, and it really does a good job highlighting some of these metrics and where can you find them and those quality evaluation systems. Again, we will look at measures. Remember that we're looking really at outcomes. And when we look at what are those measures, those metrics that are available to us, we have what is called process measures that, again, look at either the delivery of a service, or what is the outcome in terms of the utilization of certain medications. There's some surrogate outcomes, many of them are clinical outcomes that help us define if we're achieving the expected outcome and the clinical metrics for that patient. And then we have other outcomes that are more related, again, to very specific measures within these contracts. So now I wanted to move to share with you these two value-based models in which we are involved at the University of Maryland School of Pharmacy with the University of Maryland Medical System. Again, this relationship is somewhat unique because the pharmacy services that are integrated within these two models are provided by the School of Pharmacy in a contract that we have with the system. So again, one of them is going to be the Quality Care Network, where we have embedded pharmacists in the core care management team, and the Maryland Primary Care Model, Care Transformation, which is again that CMS program in which we are testing, integrating interprofessional care team in primary care practices, again, utilizing and targeting a fee-for-service beneficiaries. So let's start with the Quality Care Network. Again, this is a network of physicians, primary care providers within Maryland. So we cover the whole geographical state of Maryland. We have about 300 physicians that are part of this particular network. And the outcomes and the goals are really to establish these networks and develop high-performing services for patients that are within these value contracts. We have value contracts with United, with Aetna, with a variety of different plans, as well as Care First. And again, creating these high-performing services and providing the support to the practices. Again, this is the model that we follow within the Quality Care Network. It's a proactive, patient-centered care model in which you see that there is a core team that provides a variety of services to the practice. So we go all the way from a medical director. We have practice transformation individuals that actually work within the primary care practices to help those practices transform into a value-based organization. We have case management team that has nurses that, again, are assigned to be the main case management for the patients that are referred to us. We have social work support. Again, this is through a contract with the University of Maryland, Baltimore Social Work School. We have behavioral health specialties and also referrals. We have technology and data analytics, and I'm going to share with you later how we use a lot of these data analytics and reports to guide us in some of our work and to assess our performance. And then, of course, we have pharmacy. And again, pharmacy is really focusing on optimizing medication use by providing comprehensive medication therapy management, promoting medication adherence, drug therapy. We also focus on generic medication utilization because it's one of the metrics in many of our contracts, chronic disease management, and again, overall integration within the care management team to improve both acute care utilization, but also improve chronic disease management. So again, we have a variety of initiatives, and I'm going to share with you more detail about these in a couple more slides, but really is looking at providing that comprehensive medication therapy management. Particularly, we do a lot in transitional care. We also do a lot in complex case patients. So we have specific criteria that we share with the practices for patients to be referred to us. And again, those other services that focus on specialty drug utilization, generic dispensing, and again, multi-dose packaging. The guiding principle, again, is that we position ourselves as a working partner with the patients and the providers in these practices. And our goal is to bring in value added by, again, fitting ourselves, molding ourselves, and integrating ourselves within the culture of that practice, and being really an integral part of the services that are provided to the patients within that practice. And again, very results-oriented and aligning incentives across the board. We align the incentives to the patient, we align the incentives to the providers, and the incentives to our payer to make sure that we all are aligned in our goals and have a common goal. So these are some of the programs that we have. And again, like I stated before, with medication adherence, one of the things that we're doing is really focusing on identifying what are the barriers of adherence for the patients, and also identifying community resources that will help these patients to stay adherent. For example, one of the things that we do a lot is we partner with community pharmacists around the state that have either an adherence packaging system or have different programs within the pharmacy to stress adherence. We also look at medication monitoring, and for many of these medications, pharmacists are responsible to assure that patients are getting the appropriate monitoring for those drugs. They assess the monitoring, and they intervene by making recommendations to the primary care provider of that patient. And with the specialty drugs, again, making sure that these medications are used appropriately, and we work with many specialists that support these primary care practices. So that brings us to one of the interactions, a polling question. And as you see in your screen, the question has been highlighted for you. Really what we're looking is, based on what I said so far within the University of Maryland Quality Care Network, what are the services that we provide, and what is one that we do not provide, as we kind of ask you. So again, which of these we're not currently providing? And Amanda, you tell me how long we keep it open?
We will wait here just another moment so everybody can answer. We're still getting a couple responses. And then
Thank you.
It looks like we're good, so we can display the results.
Okay, so this is the result. So again, pharmacogenomic testing, that is correct. That's the correct answer. We are not currently doing this. So again, so I wanted to move specifically about talking a little bit more about the PQA measures. Again, I don't know if I am supposed to stop the screen or you guys can do it directly.
The screen looks fine at this point. So
okay. So it may be like in my stream it's showing, but that's okay. We can keep going.
Okay.
So again, I wanted to share with you some details specific to some of the plans and these contracts that we have to highlight for you. But these metrics that again are part of these PQA metrics. So again, you've seen here that there are many of the ones that I put in green are metrics that again pharmacy can have some impact. So annual monitoring persistence of medication, and I'm going to tell you very more specific about PQA measures that we follow with some of our contracts. Comprehensive diabetes care, again, looking at A1C control, looking at also readmissions, where we know that pharmacist intervention actually can produce very significant results. One of the things I wanted to call your attention, if you see in this particular contract, many of these metrics have a value weight. And you see in the column in there where it says weight. And again, those, the achievement of these metrics get then added up in points. And depending on what points we get by attaining them, then we either we either are able to achieve our share savings or not, depending on how they're adjusted. One of the difficulties here is that many times, let's say that we meet the annual monitoring persistent medication, but we're not able to meet some of the other metrics. Again, that particular contract won't pay us those savings payments. So again, it becomes a little bit difficult because sometimes in pharmacy, we achieve our metrics, but if the overall metrics are not achieved, then the savings may not result in the way we want it to be. So the other one that I wanted to share with you was, again, looking more in detail about these metrics. And as you see in the bottom where it says medication management, you see many of these are PQA metrics. And these are metrics that we in pharmacy are responsible for. So in many of these contracts, we said, okay, we take a look at the metrics and we said pharmacy will be responsible for those medication management and contribute to the overall achievement of the contract. In this particular slide, we also do a lot of discussion about where we're going to get that data from and what are those sources. There are about 4 or 5 slides that are coming up where I am going to share with you these dashboards. Again, the only reason I'm doing it is just to give you a little bit of perspective about what we do. So we have these dashboards, and you're going to see that they're in different topics or different things. For example, this one is in cost of utilization, and we're able with our analytics to break it down to the specific practice, to the specific provider. So these dashboards are critical for us in helping us attain these metrics. Again, this one is looking at quality, and we're able to see how are we doing in terms of utilization, particularly acute care. This other one looks at readmissions. What are we doing in terms of our metrics related to readmissions, 30-day readmissions, or any other readmission metrics that the contract might have? And then this one looking at access of care. One of the things that is critical in many of these contracts is the ability for these practices to really provide 24/7 access to the patients. So far, that access is not tied to having access to a pharmacist, but definitely having access to the resources of the practice. I wanted to then break down. Remember that I said that we do some interventions and some of the programs that we do within many of these contracts. So I just wanted to share with you in more detail what are the strategies that we do. For example, with generic dispensing, again, we identify what is the opportunity and we track month by month, where are we in terms of these percentages? And by doing that, we determine again, what is the impact that specialists are having and provide general guidance and education to the practices. And we sometimes even target specific providers and practices if needed to make sure that we meet this goal. The same thing with specialty medications, again, looking at where are those opportunities and in which contracts those opportunities are present, and then educating the providers and working with them. With med adherence, again, we look for opportunities. In this particular slide I share with you, we did a pilot with CVS Caremark, which was the PBM for many of our patients in many of these practices. So what we did is we identify within the pharmacy department and the pharmacy service in the QCN those patients that were having adherence issues, then partner and refer them to CVS Caremark for adherence packaging that was delivered to their home. So again, the idea here was to identify resources that may be outside of a quality care network, but are available to patients either through their insurance or the community pharmacy they use, and then partner with them to achieve our goals. One of the things that I wanted to share with you, because I think it's something I want you to think about, because we're working with this large healthcare system, we saw the opportunity, how can pharmacy impact the healthcare system directly? So what we're doing is we actually are providing disease state management services to the employees and the spouses of the University of Maryland Health System. So we have developed a pharmacy-based program where patients that have either diabetes, cardiovascular disease, asthma, hypertension, hyperlipidemia, and MI, those employees are eligible to join this program that is run by the pharmacist. We meet with those employees, either telehealth or telephonic, and then we follow them chronically to help them achieve the best outcomes of the medications. If they enroll, then they have their copays for the medications for those conditions waived. And again, this was a tremendous opportunity for us to show what value pharmacists could bring, not only in terms of these contracts, but to the institution itself. And if you've seen here, we identified 10,000 people that, again, met the criteria and could take advantage of these programs. This is just sharing with you some of the outcomes. Again, we do a lot of reporting for the system where, again, we identify who are the patients, how long they've been with us. And I just wanted to highlight for you here, look at that. We have about 212 patients that have been with the program more than 12 months. So these individuals really stay with the program, and then we're able to translate that into clinical outcomes. So we measure what clinical outcomes, and then we translate that into dollars, and we report to the system how we've been able to impact A1C, and as such, what economic impact that might have to the healthcare system. We also are able to measure direct savings. One of the things that in Maryland we have the data exchange system within Maryland is called CRISP. And we're able to empanel patients that we follow, and we're able to run analytics looking at acute utilization. So we're able to say, these are the patients that we are following. Again, we look at what was the overall healthcare cost prior to the pharmacist intervening. Then we're able to see what's happening as the pharmacist intervenes. Is there a change? And we're able to translate that into actual dollars for the pharmacist intervention. So this has been a very useful tool for us to empanel patients and really come specifically looking at dollar amounts. This again is the same cohort of patients looking again at pre and post at different intervals. We could do 1 month, 3 months, 6 months, and 12 months. I wanted to then switch from the Quality Care Network. Again, remember, those are not Medicare patients. Those are individuals with private health insurance that are part of that Quality Care Network. In many cases, we also had Medicaid. But then in the state of Maryland, about 3 years ago, there was a new program that was launched, and it's what we call the Maryland Total Cost of Care Model, or we also call it the Maryland Primary Care Program. And this is the one that follows very similar to what you're used to seeing with the CPC Plus. So these are for Medicare fee-for-service only. So practices that want to be part of this program join the program. They're approved by CMS. And then the patients that are Medicare patients fee-for-service in the practices become part of the program. As you see, the goals are to provide this comprehensive, coordinated, patient-centered healthcare, reduce unnecessary hospitalizations and ED visits, so again, acute utilization, and really look at the metrics for chronic disease management. In this particular program, they're focusing on hypertension and diabetes. One of the things that was really very exciting when we started this program is that in this particular model, when it was presented to CMS, pharmacists were highlighted as one of the main components that need to be available to the practices to manage these patients. So again, within this model, there's care coordination services, there's support for transitions analytics, and then the personnel that supports those practices. The uniqueness about this program is that practices could either do the care management by themselves and retain all the care management fees. So they would provide the pharmacist, they would provide the nurse, they would provide all the supporting services to the patients, or in the state, they allow the creation of what is called a CTO, a Care Transformation Organization. So many healthcare systems in the state developed these care transformation organizations to contract with primary care practices that didn't want to do it themselves, but wanted to contract with these entities to provide these personnel to support this care coordination. So the University of Maryland Medical System developed one of these CTOs that is called Transform Health MD. And again, pharmacists were integrated within that particular care management team. Again, practices could go into different tracks, track 1, track 2, depending on that. The care management fees are greater or less. If you're in track 1, they're less. If you're in track 2, they're more, but you have to provide more of these care coordination services. And it's based on the acuteness of the patients that you serve. So there is a monthly case management fee that is provided to the practice. In addition, there are layers of performance incentives depending on certain metrics that the practice has to achieve. Again, one of the questions that I get a lot is, well, how do you identify these patients? How do you decide, and help these practices identify who could benefit from the services to achieve these metrics? Again, this should be no surprise to many of you. Polypharmacy, we also do a lot of risk score, and we identify patients based on the risk score for many, many things. One could be risk score for hospitalization or a risk score for an adverse event. The types of medication, if there's recent hospitalizations and transitions of care. Again, we identify them based on what are the metrics these contracts highlight and what are the things that we need to perform on, or in sometimes could be specific conditions that we say, okay, in the Maryland primary care program, patients with hypertension and diabetes are specifically identified because those are two of the quality metrics in terms of clinical performance that is paid through that program. So again, we'll come back to poll number 2. And this is describe examples of how PQA measures have been integrated into comprehensive value-based contracts in health plans. And then using the examples that I provided to you, which of the following was described today, showing how PQA measures have been integrated into value-based contracts. And again, we're going to give you a couple of minutes to share with us.
All right, we've still got a couple of answers coming in, so we'll wait just another minute here.
Yes, no problem.
All right, looks like we're good. We can close the poll.
All right. So again, the answer here was pharmacy-specific measures. At this point, we're not doing remote patient monitor, even though we've been talking about it. And as many of you probably with COVID, we're looking into, again, how do we allow our patients to, to have some of these devices that provide us these clinical metrics. Diabetes education programs we're not doing, and none of the above. Okay. So we are going to then move into talking about one particular program that I wanted to share with you because the nature of what we did, and because this was pre-COVID, when telehealth wasn't that much in the picture, and it was a COPD program. So again, it's an example of how we look into a disease state and how, again, we could really look at some of the PQA measures as it relates to adherence and drug-related problems and acute utilization. So in this particular program, what we did is we identified patients within these primary care practices that had COPD, talked to the physicians, developed criteria, and those were referred to pharmacy for those to conduct a telehealth visit either at home or in the physician's office. So we are outfitted one of the physician's offices where the pharmacists conducted these telehealth visits. One of the things that I really like about this program is that we were part of the schedule of the practice. Patients will come into the practice, they will be checked in, like they will be seeing any provider, the MA would put them in the room, set it up, and they will reschedule the pharmacist interventions. And patients were given a tablet if they wanted to take home to do the follow-ups at home. Again, focusing a lot in the COPD assessment test, inhaler use, and having patients being able to do that, but also vaccinations, which is an area where pharmacists can really make a tremendous impact. So again, in adherence, one of the things in this cohort is they had a pretty high adherence rate, but this was self-reported. So again, we're not totally sure. There was some increase at the end, but not as significant as we thought. We tracked those COPD-specific drug-related problems, and we tracked resolution to make sure that, again, as we provided these recommendations, what happened with these patients. And again, we looked at hospitalization, acute utilization, using the same tool that I described to you before, CRIS, where we empanel these patients and monitor them to see. In this particular program, we measure patient satisfaction. Remember, this is pre-COVID. So patients did not have a lot of these telehealth type of services. So we wanted to see what was the uptake and patient satisfaction. And then we were able through CRIS to look at not only the pre and post for the patients we intervened, but one thing that we were able to do was to create a comparison group of patients that had similar characteristics, similar disease states and medications, and compare what happened to the utilization, particularly acute utilization in that cohort. And we were able to track what economic impact we had in this cohort that were impacted by the pharmacists as we compared the ones that were not. Again, remember, this is not a controlled clinical trial in which we were able to really capture all the interventions for the comparison group. So some of them could have had interventions by somebody else, but definitely we saw that in that group, costs went up as compared to the group that we intervened on. Again, one of the things that we did is we said, okay, what happened after the program stopped? Because the program was short duration. And we saw that in many of the patients, this effect and this decrease in utilization was sustained. So what are the opportunities for pharmacists as we start thinking about these value-based contracts? So I wanted to kind of reflect a little bit. In our particular case, pharmacists have the opportunity in Maryland either to contract directly with these care transformation organizations or with the quality care networks and provide the services, or they can partner directly with practices. We do have some practices in the Maryland Primary Care Program that have hired their own pharmacists. And they have pharmacists that are serving as private consultants. Some of them have developed relationships directly with community pharmacies that are providing the comprehensive medication therapy management services. But one of the things that we really have learned, and I would love to see more and more of this happening between pharmacies that are integrated into these value-based contracts and population health services, is the pharmacist-to-pharmacist referrals. So we really have started to emphasize the pharmacies that are embedded in these practices and in these care transformation, organizations and in the care management, referring to community pharmacy for immunizations. We do it all the time for point of care testing, for these adherence packages. We don't provide diabetes education, so we identified if there's a diabetes education program that is provided in a community pharmacy, we refer patients to. We're also starting to create a referral system between the inpatient pharmacists for the patients that are part of our network, the pharmacists embedded into this care management, and community pharmacy to create really this synergy and this integration where pharmacists are referring to each other and sharing a common goal or a common treatment plan. Again, some of the factors to consider as you think about engaging in these, or if there's some health plans in the audience, how pharmacists can provide value, again, is a financial, really impacting this clinical metric and humanistic. And one of the things that we're starting to see is an interest from health plans and many of these contracts on social determinants of health. And we know that pharmacists can have a tremendous impact there. And that takes us to our last interactive polling question. And it's again, the COPD pilot described today is an example of pharmacist-provided care within an interprofessional team. What were the results of the project? Did we reduce acute care utilization, improve medication adherence? Over 80% of the patients were highly satisfied with the program and technology, all of the above or none of the above.
All right, we'll wait just one more second. So if you haven't answered yet, please enter your response.
Okay.
And that looks good. We can end the poll.
All right, so majority of you again chose all of the above, which is correct. That I share with you that we looked not only at medication adherence, acute utilization, but also patient satisfaction. And remember, for many of these value-based contracts, patient satisfaction, particularly with the Maryland Primary Care Program, that's one of the metrics that is measured again. What is the level of patient satisfaction? And Amanda, I think that takes me to the end of my presentation. We wanted to leave time for interaction and questions. So I am going to stop sharing my screen and then we can go to that.
All right. That sounds good. Thanks so much, Magaly, for that presentation. There was a lot of information in those slides. We did receive a question. So thank you for that. We did receive a question about whether attendees could have access to the slides. So as I mentioned earlier, we will post those for PQA members in our member resources library, and we'll have those up for you in about a week. So thanks for being willing to share those with us, and I'm sure our members will enjoy being able to have those details. So a couple of questions have come in through the question and answer feature while you were speaking, but I would like to encourage everybody, if you have additional questions, please put those in and we can get to as many of those as we can with our time today. So the first question that came in was about return on investment and justifying FTEs. So I'm assuming pharmacist FTEs in this case. Yep. So have you used ROI to justify pharmacist FTEs, or if not, was there another method you used?
Yes, we have done that. In a particular case, and again, when you look at value-based contracts, so this relationship where pharmacists integrate themselves into these population health programs or any of these contracts with primary care practices, there are different models, right? Some pharmacists integrate themselves getting paid for the services that they provide. So if they see a patient, they get a fee for service. In a particular case, we have done it based on effort. So what I mean by that is that we have allocated X number of positions that provide the service. And then what we do is we track for many of these PQA measures. And sometimes it's very difficult because remember that we are part of a care management team. So it's not like, it's very difficult to attribute, oh, everything that happened here was because of the pharmacist. But in the particular example that I gave everyone about the self-insured, well, the employees of the healthcare system, that we're the only ones that are providing the service. So in that one, we measure directly ROI. In some of the contracts, we're able to extrapolate what impact we had in those PQA measures and what percentage of that was attributed to them fulfilling that contract. So we have done that. Again, could we, some people have said to us that maybe we should go to risk sharing and share some of those, payments. Again, we found that for us at this moment, we're better off by effort, but we are thinking about maybe for some of the portions of the contract, testing that concept of, sharing some of the profits.
So that's an interesting idea. I would love to hear the result of that if you decide to pursue the risk sharing. Interesting. So thank you. Another question that came in was around risk scores for identifying patients for your programs. Do you have a standardized method for developing a score like that? And if so, can you share with us how that works?
Yeah, so in our particular case, the health system developed their own scoring. And they developed a risk score calculation, taking into account a lot of different variables for these patients. Remember that in this particular contracts, we get a cohort of patients that are attributed to us, all right? And so we get all the information on those patients. So they developed something called a lighthouse, that's the name of the system, where they enter all the information they have about those patients, all the claim data, all the information we get from CMS. Remember, CMS provides these practices with, you know, the different risk scores for these patients and the different disease states and claims. So we have developed our own system that then share with the pharmacists for the many times for drug-specific things, or it's really shared with the care management team where we develop a hierarchy of the patients that need intervention.
Okay, thank you. Next question is maybe asking just for your opinion and if you have a crystal ball handy on this one. So wondering about chronic care management and considering pharmacists as providers. Could you see that happening under provider status, and what might that look like?
Hey, I would love to. That's one of my, I hope that this time, I don't know if you all know, but there is a bill again in Congress to make us providers, particularly in underserved areas. So if that happens, I would love to see that. We try to get ourselves integrated in some of the practices for two things, because, you know, nationwide, if you look at pharmacists working in primary care, they have contributed to two main things. One is chronic care management and really getting the practices to bill for those services, but also annual visits for, you know, Medicare patients. In a particular case, the practices felt that we were too expensive to be used for some of those services, so we're not providing a lot of that at this moment. In the Maryland Primary Care Program, these practices, because of this pilot program, they cannot bill for chronic care codes. They cannot bill for any of that because they're getting those care management fees upfront. So that is part of that particular program. So we're not really capitalizing on those codes at this moment.
Okay, thank you for that information. Next is a question about how schools and colleges of pharmacy could get involved in initiatives such as the ones you're describing today.
Yeah, so I think that we've been really lucky to have a very good relationship with our healthcare system. And as many of the schools of pharmacy are there, we have contracts for faculty that provide services in many of these institutions. So when these programs, these population health came into place, we were pretty upfront, and the dean and I went and met with the director of, with the CMO of the system. And we said, hey, we heard you're developing these population health programs. We would love to be part of it. And so we really boosted and interjected ourselves even in the development of the whole program. So we've been part of this program since inception. We helped design it. We helped do it. And we really sold to them the advantage of a relationship with the School of Pharmacy versus them hiring their own pharmacists. They could hire their own pharmacists, but they saw that two main things. One is we had a track record doing this. So we knew how to do it. We'd done it before. So they said, oh, what a great advantage, bringing in people that know how to do this, all right, instead of hiring somebody new and starting. But the second thing is they have seen the advantage of having the School of Pharmacy and all the resources for innovation, for trying new things, for students that rotate through this, to this program. So we have both residents and pharmacy students that do their experiential learning within this program. And so again, they see the advantage of workforce development, but the advantage of having all of that resource that the School of Pharmacy brings to support these programs. So again, go for it, but don't expect them to come to you. You go to them. Develop a proposal, investigate what the health systems have, and go and interject yourself and sell yourself and what you can do.
All right. Inspirational message there at the end and encouragement. So thank you for that. Next question is related to the pharmacist to pharmacist referral that you mentioned towards the end. So what method did you use for that referral? Did you have sharing of EHRs? Did you just have a fax, a phone? How did that process work?
Yeah. So in some of our pharmacies that have access to, we use Epic in our system. So if the pharmacists have access to electronic records, it could be Epic or could be others. Some pharmacies have electronic records, we refer directly. If not, we use the old-fashioned way of either a secure faxing or any other method, or telephone. So we use any of the above, depending on what capabilities the pharmacists have. We actually are starting a new project, which I'm very excited about, which is that remember that data exchange system that I explained to you, CRISP? We have developed a referral system within CRISP where we're working in another project with Prince George's Health Department, and we're able to get the pharmacists within the program to refer to community pharmacists and getting them access to that data exchange. So we're doing that particular program, we're doing referrals directly to the community pharmacy, and they can see it in the data exchange, they can see information on the patient, and we develop a data collection form where the pharmacist in the community pharmacy can actually enter some of those inputs. So we're really excited about that because it be the first time that we're trying to develop a statewide system where pharmacists can refer to each other and can also collect information of what's happening in community pharmacy that many times doesn't get into the electronic health records. So
okay.
Stay tuned.
Great. Sounds good. We shall. Next question is about if any of your programs included anticoagulation management. So if so, have you expanded beyond warfarin to some of the new direct oral agents? If you could tell us about that.
Yeah, so we currently are not providing anticoagulation services. We actually refer them, the health system has their own anticoagulation clinic that is pharmacist run. So we refer those patients to those particular clinics. We're not directly doing it. We provide education and connect the patients with an anticoagulation service, but we're not doing it directly.
Thank you for that information. And we have time for one more. I think this is a good question to wrap us up here. So it's a two-sided question. First, if a pharmacist is interested in integrating their services into a value-based contract, what's your advice for the pharmacist? Like some of the key steps there. And then on the flip side, if there is another practice site that is interested in including a pharmacist, what advice do you have for welcoming the pharmacist into the team and integrating that way? Okay.
So I'm going to take the first part. I think that my advice, and I've been preaching this to my pharmacy colleagues, is that it's very important to get educated about value-based. I think I meet some pharmacists that don't understand what value-based contracting is. You need to learn the terminology. You need to learn how these contracts work, what's included in that contract, and then highlight and identify where can you contribute and what your impact might be and how you're going to affect the bottom line. How are you going to affect the achievement of those quality metrics? Because I see many pharmacists that say, oh, I'm interested, I want to. They go and start dialogue, but they don't understand these areas. They don't understand quality metrics. They're not familiarized with PQA measures. They don't, you know what I mean? So it's very important if you're going to, adventure here, you need to be knowledgeable, and people need to know that you know what you're talking about, because I think that's the first thing to get in the door. Then develop a menu. What can you do? What services can you provide? And again, tie them to how does that relate to the quality metrics or any other performance metrics that are within that contract. So that's key. In terms of practices that may want to incorporate a pharmacist, I think the key things is to educate these practices. I think that there is at times, what I find is that I have primary care practices that come to me and says, I want to include a pharmacist, all right, within my practice. But they really don't understand what are the capabilities that pharmacist has. So again, educating the pharmacists. We actually in Maryland are developing a elevator speech for pharmacists on how to go and talk to these practices. What is it that you have to say? What are those key things? And again, making sure that you outline for those practices what you can do and what you cannot, because sometimes they're expecting you to do some things that you're not able to do because you don't have the data. You don't have. The other thing is the importance of data sharing. If you're going to incorporate yourself into these practices, you have to have access to these electronic records. You have to have mechanisms and protocols. How are you going to send your recommendations to the physician? How are you going to track them? You need to have, we even have performance metrics that we establish. How long would it be between a referral and when we get back to the provider? We should act on these referrals by, no longer than 24 hours, whatever it is. So you need to also develop those type of things. But I tell you, I think that primary care offices are really, really interested in incorporating pharmacists. Many of them are under these value-based contracts. Many of them are participating in these pilots that CMS has. So again, getting yourself knowledgeable, number one, and number two, developing a very specific plan that outlines what you can do and what value it brings. That are, to me, the first steps.
Okay, perfect. So having the appropriate knowledge and having a plan sounds good. Mm-hmm. And thanks so much, Magaly, for being with us today. We appreciate you sharing your long-standing experience with us. I'm sure we've all learned a lot from you. So thanks again for joining us.
Yeah, thank you all, and have a